Disorder of sexual developments are one of the most challenging endocrine emergencies encountered by pediatricians. The complicated pathophysiological aspects results in difficulty and confusion with regards to evaluation and management. We have developed a DSD interpreter as part of our next generation MedEClasses mobile application, which allows careful interpretation of DSD disorders based upon the basic tools. So all you have to do initially is to just put in information about the presence or absence of gonads and Mullerian structure, and based upon that specific questions are addressed, subsequent to which there will be interpretation and diagnosis of specific disorders. While developing the algorithm, we have tried to use a simplistic approach which minimizes excessive workup and investigations. So what we have done is that this algorithm, which is being used for the development of the mobile application, essentially talks about two things initially: whether there are gonads there and Mullerian structures present or not. And based upon that, we've got this 2x2 table of palpable gonads with Mullerian structure suggesting a over-testicular DSD, palpable gonads, no Mullerian structure, or no palpable gonads or no Mullerian structure suggesting a XY DSD, and no palpable gonads and Mullerian structure suggesting a XX DSD. We have therefore categorized individuals into these four groups, and the workup is then decided based upon that specific category. So all the individual has to do is to fill in about the information about the palpable gonads and Mullerian structure, and then the investigations come up. So we have this day 3 child with disorder-sexual development with stage 4 Prader development, no gonads and uterus present. So of course, when we put this in the app, we have got a palpable gonad which is absent and Mullerian structure present. It indicates XX-DSD. The key things to look at are sodium and potassium along with 17-OHP and maternal virilization. Now, hyponatremia, hyperkalemia, and high 17-OHP clearly suggest a possibility of 21-hydroxylase deficiency, and then from there you will get guidance with regards to further evaluation and management. Another similar child, day 3 child with DSD, again stage 4, no gonads, uterus present, 46XX, had a marginally high level of 17-OHP as far as the reference range which was written. So the treating physician labeled as congenital adrenal hyperplasia. If we put this again in our interpreter with palpable gonads and Mullerian structures being there, no gonads, it will ask about maternal virilization, which was present in this case. Now this 17-OHP is not very high, sodium potassium was normal, so this clearly is suggestive of aromatase deficiency, which was confirmed on genetic studies. Interesting 14-day-old child with atypical genitalia, bilateral gonads present with no uterus, indicative of a XY karyotype. And when we evaluate in this regards, we have palpable gonads and no Mullerian structure. The key questions now are about the testosterone status and the electrolyte status. So there is hyponatremia, there is hyperkalemia, there is slightly high testosterone, and the DHT was appropriately normal in that perspective. So if you look in this scenario, this is a classical case of 3-beta HSD. There is a combined adrenotesticular defect with peripheral conversion to produce testosterone and 17-OHP. So this is classically 3-beta HSD as indicated via our DSD interpreter. Now this again a 14-day-old child with asymmetrical genitalia, asymmetrical especially with right side being testis, the left side looking more like a feminine appearance, uterus was present on the right side, and there was a XX karyotype. If we put this data in the interpreter, we have got a palpable gonad and a Mullerian structure, a rare scenario, and asymmetry is there. Hardly anything else is required. The diagnosis is of over-testicular DSD. 15-year-old girl with delayed puberty, again highlighting individuals who present late with DSD, inguinal gonads and primary amenorrhea. There were no Mullerian structures. So if we put in our app, you talk about palpable gonad being present and no Mullerian structure. The questions are mainly about electrolytes. So this was a XY DSD, and the testosterone levels were extremely low. The next vital question in this scenario is the blood pressure and potassium, and here there was hypertension and there was hypokalemia as indicated, and this suggested the diagnosis of 17-hydroxylase deficiency. 12-year-old boy with hematuria but no palpable gonads and uterus. So this is a scenario wherein we have got a DSD because there is no gonads and there seems to be extreme virilization in this individual presenting in a male form. So if we put the data in our interpreter with palpable gonads absent, Mullerian structure present, the questions are maternal virilization, Then of course XX regarding the blood pressure. So there is hypertension which is there. There is hypokalemia, and this clearly suggests that we are talking about a XXDSD with hypertension in which there is extreme virilization suggestive of 11 hydroxylase deficiency. So this is how we approached this particular situation. A 15-year-old girl with primary amenorrhea with a reasonable height, stage 4 breast development, mild pubic hair development and inguinal gonads. Uterus were absent, so we have got gonads present, uterus absent. Again, XYDSD. Let's put in our interpreter. It will ask about gonads being present, Mullin structures being absent, electrolytes were normal. Of course, at this stage, we expect that to be normal. Testosterone levels were high and DHT was reasonably appropriately normal. So this is indicative of androgen insensitivity as identified by the application. 10-year-old girl with clitoral enlargement. So this girl had normal development earlier, and now the parents have noticed about clitoromegaly. There is a phallic length of 2.2 centimeters. Gonads are present and uterus are absent. So again, XYD. And if we put it in our application, it basically asks about whether palpable gonads are there and the Mullin structure is absent. It talks about electrolytes, which were normal in this case. The testosterone level were on the higher side with a low level of DHT. So this indicates that there is production of testosterone, but it is not getting converted into DHT, and this along with the pubertal virilization is suggestive of 5-alpha reductase deficiency. The mobile application is readily available on both the Android and the iOS platform. All you have to go is to go there and search for MedEClasses. You will get the application there, and once you get there, you can easily download it. If you have an existing version, it's best to delete that to allow a successful install with a subsequent. Once this version is installed, you will be able to register with the basic information which is provided, and registration will allow you a 7-day complimentary access to the use of the mobile application. MedEClasses endocrinology application, pediatric endocrinology on your fingertips.